did you want to start with? The one you edited or Melody's?
Attendees are advised.
I'm on mute. Sorry.
It's okay.
So I guess, just kind of wanted to talk about how we rolled out this training and then kind of get thoughts. So there's two ways that we could do this. I know Melody had done kind of her initial training that I really kind of borrowed heavily from or stole and kind of made more Peoria specific. And then she also has done a training video. And so she had offered, to put together a training video. And that certainly could be an option. My only thought is if we did more of the traditional PowerPoint video, then anyone throughout the state could alter it to kind of fit their jurisdiction of like what resources and things were available. So I was leaning more towards continuing like a PowerPoint format, but just wanted to see what you guys think.
Yeah, I think a PowerPoint format would be okay.
In terms of which one to do, I'm not sure which version Melody had sent, because I know she had sent me a couple versions and then I took hers and made some adjustments. So we can start either one. I don't know if hers has a date in it in terms of how recent it is.
Let me see. I'm not sure. I mean, yours had more of the like T3G algorithm and
throw the ADHS logo one.
Sorry, Shelley, you were super quiet there for a second. I couldn't hear what you were saying.
Do you want me to go ahead and just copy and paste them together with the ADHS logo?
I mean, whatever one we do, we need to put on the ADHS logo. I think we just have to kind of start with one and start going through it to see. So,
do you have a preference?
do you think yours would be better for more general?
It might be because I tried to do it more. Yeah, so obviously the title would just be more, obviously ADHS branding information. So you could take off all my information.
Mm-hmm.
Delete. Hey, is that Melody?
Yes, it is.
Hey.
Just joined. Yes, I'm on a shift at Kodak, but I'll be here for most of the meeting.
Oh, excellent.
Thanks.
So we had just talked about kind of whether we worked on developing a PowerPoint that could, in an individual jurisdiction, be kind of altered to fit that jurisdiction's resources versus the video. And so we were thinking about more sticking with the PowerPoint format to kind of match the other trainings, which then would allow any agency in their medical director to kind of make it more specific. So.
I like that. I think that sounds great.
Okay. And you will, I don't know if you are at the computer, but if you are, you would recognize a lot of these slides.
Nice. I'll pull it up. I'll log in from the computer.
All right.
Great.
So I think, one of the pieces that I liked a lot about Melody's approach to teaching this is to not just focus on like how and when to give Narcan, but also to kind of destigmatize some of the issues related with opioid use and kind of overdose. And so I think kind of getting into some of that is what I continued over from her training as well.
Okay.
I found that to be useful because sure, we could do like a 5-minute training on here's the Narcan, give it out, but it's more than that, I think.
Yeah, for sure.
I think Shelley uploaded another PowerPoint that I did. I sort of revised these slides for Picture Rocks earlier today. adding just a few slides on medications for addiction treatment, even though we don't offer them, but just to provide a basic training for our providers so they can answer questions and educate patients, and making the protocol a little simpler as well. They're the same slides.
Okay. So do we want to just go through kind of slide by slide, and we'll start with Gail's, and we can go back to Melissa's and those new slides she put in, and we can start with this one.
Yeah, Amber, do you want me to do edits, or did you want to do edits?
You can do them if you'd like to. You've already got it pulled up, so.
All right. Goal today. That was fine. Next.
Yep.
Talking about the disorder.
Mm-hmm.
Next, looks like TTTG format.
So this one just would need, so the future rollout that can go off, that was just kind of with that department wasn't ready to kind of do it yet on 911 calls. So they were instituting it more on like a community paramedicine. But what do you guys think of this in terms of kind of the inclusion, exclusion criteria, and then kind of the protocol itself?
Is this one part of the state T3G scale, or is this just formatted to look like the other one?
Just formatted to look like it, yeah.
I was just going to look at what Melody had on hers really quick.
I feel like it was pretty, I feel like I used what Melody had, but just put it into the TTTG format.
Okay, so pretty much the same then. Okay. Okay, perfect. Oh yeah, it is. Okay. Perfect. Yeah, I think it looks good.
I just have a question. Sorry.
Yes.
And it may be kind of covered somewhere else. I don't remember, but it's kind of focusing like on illicit drug use, like rather than. I think there are two different classifications of people. To be honest with you, I think there's those that use the drug for recreation, and those that have medically become addicted to. And it seems like this might put a little bit of a stigma on that. Is it just me, or?
Well, it looks like there's prescription opioids listed in the first line of
Yeah,
the
it does say illicit drugs or use prescription for opioids.
Yeah.
Then, you know, physical environment with illicit opioids or paraphernalia, high dose prescription opioids present.
Uh-huh.
So it's probably just me. It's probably fine. I just kind of have some strong feelings that there's a whole medical side to this that sometimes we're not quite as compassionate with as we are with our other types of patients.
Mm-hmm. Well, let us know, Sandy.
I think they cover that in the education and just say that like a large percentage of patients who are dependent now, it's from iatrogenic dependence, and they've been, following doctors' guidelines. But ideally, we wouldn't want to stigmatize either group and just offer both groups non-stigmatizing treatment.
Right.
Mm-hmm.
Okay.
Thanks, Sandy.
I appreciate what we're doing.
And then are we going to include the pamphlet with the training? Gail, was that the intention? It sounds like it probably is, but.
I think so, as kind of some templates, because I know I shouldn't say I took Melody's one and then Peoria adjusted for like resources that are available in their jurisdiction.
Right.
So I think we could use like, here's some templates of a pamphlet or brochure that you could put your own jurisdiction's resources available into it.
Okay, cool. That's what I was sort of picturing us doing here, but it's listed in here specifically, so.
I do think it's a key part is to provide resources,
Absolutely.
so that we're not just like handing a Narcan. It's like giving someone a Band-Aid, but not addressing the issue.
Mhm.
I really like to put this in the TC3 format. It looks really good. But for our agencies, we were still giving the naloxone even to people who had signs of overdose and who we were transporting to the ED.
And I think that was, this agency was just a little bit more hesitant to do that because they, in their mind, they were like leaving it. But I think that is a good point because if they go to the ED and then they get to the ED and they leave, they may be leaving
Right.
without Narcan. So do you at least give it to them pre-hospital? I think that's reasonable for sure.
Mhm.
So you're thinking about just getting rid of excludes and just moving that bullet
Yeah.
point up, or actually that whole section could get removed.
Yeah. Because obviously we'll treat them differently if they're, if these patients need to go to the emergency department, but most EDs still aren't giving out Narcan, so at least we can do it.
No, it's a great point. Yeah, thank you.
I mean, do you want to put in your like EMT treatment then instead of like as an exclusion to the leave behind? If patient exhibiting signs and symptoms of opioid overdose, make sure that they're also treated and transported in your like actual treatment.
Refer to the overdose protocol or something like that.
Right.
Because
Yeah.
it's just be used in addition to other protocols.
Stop removing the
It's not even exclusion, but just refer to other relevant protocols for altered mental status and overdose or something like that.
Right.
Or
Exactly.
cardiac arrest, whatever.
Right. So it's not necessarily one or the other.
Mm-hmm.
Yeah.
Is that how you were thinking it should look?
Is there an overdose protocol, or most people have an altered mental status /
Let me quickly look at the TTTGs since this is statewide.
be putting that in the EMT treatment box? I don't know. Where do we want to put this?
Yeah, I think it makes sense to do it in the treatment box.
At the top, maybe? I don't know. Or at the bottom. I don't know. I don't know what's
So
better.
we have an opioid poisoning / overdose. I think probably overdose or altered mental status because it would come up under either one.
Mm-hmm.
So overdose or altered mental status protocol. Or I guess we should use guideline for consistency for the TTTGs. We call them guidelines instead of protocols.
Yeah.
I just double checking on the app which way we had it listed at the state ones.
So like as applicable or as, I don't know, if applicable.
Maybe I would say if signs of, so start the bullet with if signs of respiratory distress
Yeah.
/ respiratory depression, maybe respiratory depression / arrest.
Mm-hmm.
Or altered mental status, refer to.
What you were thinking?
I think so.
All right, we'll move on to the next slide.
And this one, I don't know if we're actually allowed to use Oprah memes. If we're distributing it to the state.
Are you saying we have to use
Until we-
copyrighted stuff at the state level?
Exactly. You know, for small agencies, sure, no one's going to look twice, but.
Yes, Shelley keeps us out of trouble like that too.
I'm pretty sure we have memes in all of our education.
I like it. It obviously sets the message.
What do you guys think? Keep her or Shelley? You're the one that always keeps us out of trouble.
If my brain isn't turned on. I
Sorry,
think
I couldn't hear you there.
if my brain is engaged, yes, that I could have potential to keep us out of trouble.
Only when she's paying attention.
I think leaving the meme until we get our wrist slapped is fine. I'll move on to the next slide. You want to keep the same document link?
Sorry, on the last slide, the thing about filling out a survey, I don't know if we want to keep that or just say document
Yeah, I think
for agency.
maybe document or the whole change the whole bullet. So maybe document distribution per agency's policy.
Yes, that sounds good.
Yeah.
All right. That one speaks for itself.
Mm-hmm.
Next is slide 7.
Again, stolen from Melodies. But I think these were all really good. It just kind of gets that mindset of like, this is just another emergency that we should be taking care of just like anything else.
Yeah, I always like the terminology like time sensitive as well when talking about this type of stuff because it
It truly is.
same category, right? Of like stroke and STEMI and that there really is like a time sensitive component to this over other 911 call types.
Are you thinking changing the title to
No, I think it's fine, but you know,
just
Like if-
reiterating that point?
yeah.
Put in the note.
I've also heard this referred to as chain of survival. You know, we use that term a lot for cardiac arrest, but you could also use it for opioid overdoses.
Yeah.
I like putting that as a teaching point there, Shelley. That's good.
Next slide. Slide 8. Some notes at the bottom.
And if you want to send me any of this to like look for the citations for the images or alter it so it's more EMS specific instead of ED, I'd be happy to do that too. It's like lots of the comments here are more ED specific.
What do you think? Can you expand those comments for a second, Shelley?
Yes, ma'am.
Thank you.
Do you want me to read them?
I think everyone's on the computer.
I know sometimes it helps to get it.
That's true. What do you guys think? Do you think it needs to be more EMS specific?
You just change ED to EMS or ED/EMS.
Yeah.
Also, when I use this slide, I started telling people, and also because people don't usually respond favorably when we wake them up from an overdose with naloxone. So it's not like a happy, joyous encounter lots of the time.
True.
No one's thanking you, even though it's a big deal. So maybe adverse effects of opiate withdrawal, of overdose reversal.
All right, want me to move on?
Mm-hmm.
All right. Slide 9. And I can move on to slide 10.
Mm-hmm.
Always shocking to see the rate of addiction.
Yeah.
And I'll move on to slide 11. Right, good info.
Mm-hmm.
Is there any updated data other than 2013? 6 years ago.
You know, there's a lot of like smaller level data, but like the actual true like national data, there's surprisingly not. I haven't been able to find great graphics. I don't know if you found anything better, Melody.
No, it's been hard to actually find graphics. And also, I think that we're still in this third wave of synthetic opioids. So maybe it started in 2013, but it's still very much underway now. And if you look at the local data, the overdoses that involve fentanyl has gone up 4 times from 2017 to 2021.
Yeah, like the Arizona Opioid Fatality Review Board that reviews all the fatalities, like it's almost all synthetic opioids. And very few now are getting prescriptions. I think that's the other big change.
Agreed.
Give me to put like Arizona seeing a trend.
I also have a slide in one of my presentations that just shows how overdoses have surpassed MVC fatalities as the #1 cause of accidental death and injury, which I think is interesting from an EMS perspective, because that's why modern EMS was founded. You know, we still have all this focus on trauma, but not so much on overdoses. I could find that slide.
Yeah, I think that would be a great one to add.
Yeah, there is one in our Narcan presentation, our police officer one that has, but it's from 2010. But it's a little graphic about the it was about the time when that started to occur. But there is one in that presentation.
All right, make a note to maybe look for updated data. I'll move on to slide 12.
I like this slide a lot.
So,
All right, everybody good? I'll move on to slide 13.
Looks good.
All right, I'll move on to slide 14.
Looks good as well.
All right, let me just slide 15.
great. I love this stuff.
That looks good.
Yeah. And this is from our opioid reports that go out from the EMS data. So I think, you know, people kind of like wonder what all the EMS data that this report is actually created from that.
Slide 16. I guess we do have updated from September of 2020, right?
I have to see if we have the graphs. I don't know if we have these actual maps updated.
Oh. All right, slide 17. All right.
In my, let's see. Oh no, never mind. That's the next slide.
Slide 18. Location examples. This bottom one says North Carolina. Should the top one just say Washington?
Yes, I couldn't figure out which county it came from. And that took a long time for someone to catch that. Thank you.
I can move to slide 19.
Think so.
I like this one too. I think it's sort of important to make them understand like what a significant chronic disease this is and how bad it is when you compare it to things like heart attacks and other illnesses where, you know, this is way worse than some of those things. So I think this is a good slide.
Is it okay to adjust Boston to Massachusetts? Is it state data?
I don't think so. I think it was
City
just
data?
other
Okay. All right, moving to slide 20. Slide 21.
And I would like to put in the education in the comments box that lots of this content is thanks to Sonoran Prevention Works training. Just to give them a little bit of a shout out.
Which reminds me, I owe you a reply, Melody.
Oh no, you're fine. You're fine. No worries.
I can add that at the beginning. Like in the notes section, or do you want it on the presentation?
I think it's in the notes section.
Okay.
And they, yeah. That's good.
Some content courtesy of Sonoran Prevention Works.
I like that.
Let's see, where are we on 21?
Yes, I think so.
Pulling up the notes part.
Wonder just the abbreviation PWUD we should probably spell out.
Yeah, good idea. Yeah.
What does it
People who
stand
use drugs.
for? We're good with that one.
Real bummer, too informal for this.
I think every family can relate.
Yeah.
All right.
And I think part of the education with this is to try to realize like there is such an issue with opioid use disorder that within every department that runs on calls and people make negative comments, they don't often realize that the person in the truck with them has a family member who has an opioid addiction. You know what I mean? And so I think just that constant reminder of like this is everywhere around us is useful. So I think sometimes using kind of that casual terminology may actually be beneficial.
That's good.
It's not super inflammatory verbiage for the huge disappointment that's going on. Slide 22. All right, slide 23.
Do we need to explain what is buddy system?
Probably. And you put in parentheses, not using alone. And instead of syringe exchange, I would say syringe access program.
Oh, good idea.
Everybody knows what MAT stands for?
No, we should spell it out.
And the new terminology for that is medications for addiction treatment instead of medication assisted treatment. So medications for addiction treatment is the preferred.
So MFAT.
Yeah, there's so many. They keep changing it. There's like mode and there's MAT and everything.
Do you want MFAT on there?
I don't know if that's a true term. It sounds like that's what the new acronym would be, but I don't know if that's a real acronym.
Because it used to be medication assisted treatment. And then people were like, that shows stigma because it's medications are seen as secondary to treatment instead of primary. So anyway, we can put MAT in parentheses there because we'll probably refer to it as MAT again.
All right. Everyone likes slide 23?
Mm-hmm.
Moving to slide 24. I'll pull up the notes part. I'll just write out on the other hand.
Mm-hmm. So I think this is the part that we may have to sell the whole education committee on a little bit, but I think is really important is this component of the training, to kind of view this as a illness, just, or as you said, an emergency, just like anything else, but recognizing what their own biases that they bring to the table, kind of how that affects us. So I think this is really important.
I agree. This could be seen as political, and I just wonder if there's a way to tone it down somehow. But at the same time, I think it's important.
All right. Move on to slide 25.
Is everyone, sorry, just go back to that one. Is everyone good with that slide?
Mhm.
Yeah.
Yep.
All right.
All right.
Thank you.
Personally, I love this slide because I just love how dangerous alcohol is that we all just accept it. I mean, I guess we did try prohibition, but it didn't work.
Yeah. But like, or any chronic illness, you know what I mean? I think we tend to treat a lot of sequelae of chronic illness very different when it's not opioid abuse.
Yeah.
I'll lift up the notes section. Yeah, there's always a campus newsletter. Any changes for this slide?
I don't think so.
All right, here's slide 26.
One slide, one change at the bottom of the slide. It says even though alcohol is more dangerous than other drugs, we can say than many other drugs. I don't want to do a blanket statement.
All right. And the next one is slide 26.
I've also taken this out of some of my slides recently, so I feel like it's a little redundant, but I don't know what you guys think.
Maybe a little bit extra. I don't know that we need it if we're, you know, wanting to cut something. I think there's a bit of this already.
Delete.
Yeah, if you guys think delete, it's always better not to be repetitive if we feel like it's covered elsewhere.
Going once, going twice. All right, the news, slide 26. Pulling up the notes. Should I change all this to naloxone instead of Narcan?
Yeah, please.
I can always do a global at the end. All right, I'll make a note to global, to swap out Narcan and for naloxone. Slide 27.
Sounds good. Yeah, I like this slide just kind of demonstrating like worldwide that this is something that's recommended.
Slide 28.
I've also started taking this one out too because it's such old data.
It's reasonable to take it out then if it's pretty dated.
All
And it
right.
also just seems like it makes sense, right, that people would use it if they had it. I don't know if we need a study to say that. And some of the other data has better outcomes, like how many people have been saved.
Everybody like slide 28?
Mm-hmm.
All right, here's slide 29.
A typo in the last sentence that may delay calling 911.
All right, I can move on.
Mm-hmm.
Slide 30.
And not to necessarily add anything to this, but when I teach this to EMS providers, I also say, like, you don't need to be worried about this teaching delaying your on scene time because you don't have to do a very robust teaching. Like, a basic training is fine.
Do you have that in the notes down there?
I don't, but we could probably put that in. No need to delay scene time with a lengthy training.
Okay, yeah.
Does that look how you want it to look?
Yeah, it looks good.
All right, slide 1. I'll lift up the notes a little bit.
Do we want to say does not appear to or just does not increase?
On the third
Good point.
bullet.
Let's get rid of the appear.
In the title.
Yeah. I mean, this is enough data that we use to make other statements like that.
Or say like is not associated with. I mean, that's sort of our other. terminology.
I like that ad.
All right, I'll move on. Slide 32. Last bullet, take home naloxone.
So, what was your question about that, Shelley?
I just changed the last bullet,
Okay.
distribution of take harm to take home.
Oh, thank you.
All right. Everybody good with that one?
Yeah.
Moving to slide 33. Ability.
I'm trying to think if we should reword that last bullet. Naloxone is extremely safe, and the person. I'm trying to think if we say the person who has overdosed made the decision to use, or I'm just trying to figure out how to reword that, but differently when I read it again.
You could just take it out like the rest.
But I think it is an important point. I'm just trying to figure out how to word it. Because ultimately to be held liable, you have to have caused the injury, or you know what I mean? And so EMS isn't causing the overdose. We're providing something that could reverse it. So I think it's important. I'm just trying to find a better way to maybe word that.
So you can say something like, I mean, similar to other acute medical problems, or similar to other EMS treatments, the provider was not responsible for causing the medical emergency or something like that. I don't know. I see what you're trying to say, though.
Yeah, just like when we give, in the emergency department, when we give insulin, we're not responsible for someone eating a lot of sugar, you know?
Right.
Yeah, that needs to be written down, but
Maybe instead of harm, the word risk.
I think I don't think it's risk though. I think you have to prove negligence and harm in medical tort,
Okay, I see what you're saying.
or like injury. You can change harm to harm/injury.
Everybody likes this phrase. All right, I'll move on to slide 34. You're not gonna be able to read this one.
And those are just the screenshots from the executive orders and the standing orders, which do need to, the next one needs to be updated, but I don't think we've even updated ours on the website with Rachel's name yet.
I'll make a note, slide 35.
So we will need to get that updated anyhow. If you want to maybe make a note on that, Shelley.
All right. I'll put a note for the next committee meeting.
Sorry, Shelley, you got really quiet there.
I'll make a note for to have this by the next committee meeting.
Okay, thank you.
All right, meme of Oprah. I like it. Effective. Slide 37.
We just can match this one to the previous version. So maybe just copy that whole slide since we made some other changes at the top.
Okay. Making up slide 37 as a copy of the above. Slide 38.
So this I wanted to get your thoughts on, Melody. I am thinking at the state level, just because right now there's tons of funding for free intranasal naloxone, that we keep this focused on just intranasal.
I think that's a good idea.
Okay.
I don't know if it's really a package of two. Is it?
Yes.
Cool.
Yeah, the box comes with two of them.
Oh, that's awesome. And we should take out the thanks to Norm Prevention Works at the bottom, because that would be thanks to ADHS. Because Norm Prevention Works is the one giving out the IM kit, intramuscular kit.
Are they doing the auto injector, or what version of the IM kit are they using?
Have their own. So I guess there's like this harm reduction buyers club, you know, like the Dallas Buyers Club, but it's for harm reduction agencies. They buy all this cheap Narcan, and it's just like the individual. So their kits come with 3 doses, which is 3 syringes, 3 needles, and 3 vials. Yeah. So they've made their own kit, and it also includes like a how to recognize an overdose, how to give the Narcan and what to do afterwards.
All right. I may have missed some of the conversation on slide 38. Gail, is this staying?
Yes. Yeah,
Okay.
I was just confirming with Melody that we didn't need to add in the intramuscular version as well.
I see.
This will be an easier sell for agencies, at least to get them started.
Jim,
Especially if we have enough supply.
make a placeholder for the information that Julia has?
I think we should probably, I'm trying to think of how, because this is going to be what we would teach. So we should probably have that as more of like an addendum to the PowerPoint. Like if your agency would like to get naloxone, you'd reach out to that link.
Yeah, good, yeah.
Slide 39. I don't know if you'll be able to hear this. Can you hear that?
Yeah.
Yeah.
Very nice. Slide.
Nice. I like that.
That's from you, Melody.
I don't think I put that in. That wasn't my video, was it?
That wasn't?
I don't
I
think
thought
so.
it was. Did I put that in?
I don't think so. I don't know. I don't think I'd be complimenting my own.
That's pretty funny. Maybe I did. I don't remember. We probably just need to make sure then that wherever that's from, I don't know if there's a link that it's a publicly sourced one that we can use.
Yeah, good idea.
I know for the PACES one, we did include several like videos that were from like publicly available, but I don't think it's the manufacturer. So I think that's at least a good thing.
You'd think Canada would be down with us using it, but who knows?
All right, I'll make a note to check for public use. This is slide 40. I might take this meme out because I don't know if I can change the Narcan to naloxone.
If you can make memes, we've got a whole new career for you, Shelley.
This one doesn't pass the can adjustment test for me, so I'm gonna cut it.
Got it.
All right, I'll move on to slide 41. Any comments? I'll move on to slide 42. And I'll move on to slide 43. This is a location-specific slide.
Yeah, so I think this one we could just delete the top
Okay.
and maybe just say in the title, just say agency specific education pamphlet.
And like that.
Does each agency produce their own pamphlet, or do we have like a statewide pamphlet?
You'd almost need to make your own because that's the first page. So like this page is the same, could be the same for across the board. But if you, when we go to the next slide, the next page, you'll see this is going to be like your treatment areas. So some of those are statewide, like the oral line, but others are going to be really what's in your geographic area.
Got it.
So I think like we could leave in the, can you make the pictures a little bit bigger, Shelley, the slide, just so we could see the details? So I think like the oral line is statewide, but then the rest of them I think are all like geographic. Crisis response, is that statewide as well? Crisis Response Network, does anyone know?
I don't know.
I would think.
Do you guys have that in Southern Arizona?
Not that I know of.
No, I don't think so. We usually send them to Kodak or the CRC.
Yeah.
So like, and we don't have Kodak here. So I think I was just looking up. So I think the oral line is probably the only one that is statewide. So we could leave the oral line and then just
Leave these other ones just as examples so people know what they should be putting down.
and then maybe just a little in the title one, just say example
Yes.
for the example agency specific pamphlet.
Yeah. And is Sonoran Prevention Works still officially doing syringe distribution, or are they just sort of?
I don't know. So I know that was getting a lot of bad publicity.
Right. You can at least say harm reduction education or something, naloxone distribution, because I think they split off. I think they were doing syringe distribution, but now a shot in the dark does that in Phoenix.
Mm.
They
So
were
maybe just
founded by the same person, but then split off.
So maybe just say Sonoran Prevention Works and take out the syringe exchange.
Yeah, and say like harm reduction services, because that's kind of vague. Because I think that they do kind of still distribute, but not officially.
But yeah, that makes
So
sense.
if you just replace the syringe exchange with harm reduction services.
I'm just looking at the website.
The Center for Rural Health has drafted all of those resource cards for each of the counties. Would it be appropriate to link to those or?
That's a good
That's a good idea. That's a good idea.
Yeah, Joyce put all those together earlier this year, so they're pretty up to date.
Right.
Maybe we should add a slide that gives a link for where people could go to get it specific for their county.
Although those, some of the rural health ones don't specify what the different agencies offer, I don't think.
I see.
I think the last I looked at them, which we have some abstinence-based places on there that are listed as well, which might be confusing for people if they're looking for that. But I think that's something we should definitely tell at the education committee, like, hey, just like we're sharing the link for ADHS where to get the naloxone, we can share the link for the local resources through rural health.
At the very least, I will remove that syringe exchange bit, and then I'll get with Julia on the county information to put in here.
Sounds good.
Slide 45.
Looks good.
Slide 46.
That one looks good.
All right. Slide 47. Looks like the bottom is cut off. I could try to redo this.
Yeah, I mean, the bottom of that one has the stuff about, sort of what the exceptions are or what you're allowed to, has a little bit more info. I don't know that it's necessary, but.
Same. I don't think I included it on the original because it was too much stuff for one slide, but in the comments, I figured the person giving the training could sort of go over what it means.
Mm-hmm. Yeah. Yeah, I'm okay with it either way.
When it says the law also sunsets in 5 years, do you know when that date is?
What was the question?
In the notes part, it says the law also sunsets in 5 years.
That's a good question. It's kind of interesting though, because I was talking to a law enforcement officer from Santa Cruz County, and she was saying how they still run everyone's warrants, even with the Good Samaritan. So people are still getting arrested, even despite this. So.
Yeah, I think it's definitely law enforcement agency specific.
Yes.
slide 48.
I think the next ones are going to probably be jurisdiction specific a little bit once we get into them.
This is slide 49. Here's slide 50. Did you want me to adjust the verbiage for the MAT?
Yeah, please. Medications for addiction treatment. I love that graphic. That's cool.
That's not yours?
Oh, it's not mine.
That's funny.
You're funny.
I don't know what that says about my memory. I think that may be a bad thing. Maybe you guys need to do Alzheimer's check on me.
I was actually thinking yesterday when we were doing the other training how good your memory was. I was like, how does she remember this from the last time we did this? It was years ago. You remembered all these things, so.
Some of that just, I remember the ample debate several years ago.
Probably.
All right, slide 51.
So this was the one that we'll need to adjust because this was taken straight from the other. So I think this one, maybe we just take out all the other ones. Is there CMS clinics in Southern Arizona or no?
Yes, there are.
So I would take out Sonoran, Prevention Works, crisis response, since those are more localized. And maybe CMS, we just take, like, we keep that, but just take out the address and phone number and just include the website.
All right.
And then I think the other ones are specific as well. So we'll need to take, because is Recovery Innovations they have a couple here in Phoenix area, but I think it might be, do you guys have Recovery Innovations in Southern Arizona?
I don't think so. Melody would obviously know better, but I've never heard of them.
Okay. And then I can see if there's like a 1-800 number for CMS. And then just make it, it could just be, and then like maybe just do one big box, and then underneath those two, we can say any agency or any jurisdiction specific resources. So yeah, there is a 1-800 number. So it's 855 203 6352. And it looks like they have quite a few across Arizona. Everything from Safford to Sholo, Sierra Vista, Yuma, Nogales, Lake Havasu, Kingman, Buckeye. So it looks like they have kind of all across the state.
Well, I'll make a note to add a lower box asking for jurisdictional resources can be put here. P2.
I think this one we can delete.
Deleting.
Yeah, it can be deleted. And then this one. I think this is going to be.
You probably delete
That's-
this because this is specific and just have the documentation slide and then say, for your agency.
That's what I was thinking. Yeah, documentation per your agency's policy.
And maybe in the education, we would say, there is probably different documentation for a patient versus a non-patient.
So this one's getting deleted, the survey one. This one looks how you want it to look.
Yeah, I think so.
Yeah, that's good.
And then next one would be this one.
I get rid of the fill out a quick survey and say perform documentation.
I'll bring this one back. Is that what you're saying?
No, delete that.
No, sorry.
Add the very last bullet on this slide under summary. Just say document per agency's policy.
Oh, all right.
And then the next slide, I think just will need to match the other guideline ones.
All right, I'm just gonna note for 54 to match. This has talking points in the notes.
I don't know if we want to include this or not. I use this this is education as far as why it's okay to, if these patients refuse transport, but I don't know if that's the direction I really want to go on with this training. And that's sort of separate. That's like a treat and refer.
Yeah, I think that one's tricky just because some agencies may not be comfortable with that, or their medical directors may not be comfortable.
Yeah, I think I would take this out because this is a whole different topic in a way.
All right.
And then Melody, you said you had a couple other slides that you've added in.
Oh, no, this is great. I don't have any, this is good. I have nothing else to add.
Well, you definitely get 99% of the credit for my lecture because I think heavily from it.
Prevention gets part of that too. So I'm just really happy to see that you found these slides useful.
I'm gonna save my work.
It makes me really excited that the state's interested in potentially, rolling this out throughout the whole state. So that makes me really happy. Thank you for your support with that.
Yeah, thank you. You kind of broke the barrier, which I think was the the hardest step, was getting someone to do that. And then, do you want to quickly share, Shelley, what Julia had included in terms of where people can get the naloxone? Because I think my thought would be that we kind of distribute this as a packet of information, like here's the standing order. Like when this goes out, I would like to try to say, here's the statute and standing order that allows you to do this. Here's a training PowerPoint. Here's where you go to get naloxone, and here's like a template of a handout for patients. So it would be pretty easy, hopefully, to then institute it.
I'm afraid I have to hop off, but thank you guys for everything.
Thanks, Melody, for all your help.
Bye.
So my question, Julia, for you is, I got the impression from the Center for Rural Health, they would have to do a whole other training. So I would almost not send that out unless you guys think otherwise. What's your thoughts on that?
Well, I was just gonna say, depending on when this training even goes live, like the grant, this particular grant only lasts through October.
Yeah.
And so, you know, it obviously won't be around forever. So if we wanted to just refrain from having it in there, unless agencies have already taken the training and are already ordering from there, then obviously they can continue to do so. But I don't know, that's my question.
I think I would lean to just linking to the Office of Injury Prevention, because I think if we want them to do this training and then also go do one of the FR Care training, now they would have to do like 2 separate training exercises.
I mean, what would they have to do 2 separate trainings though? I mean,
So,
because still couldn't this count for their training? I mean, as long as they weren't law enforcement needing the law enforcement version of it.
I think that
try
there's
that.
clarity there, because Joyce said that, and I think this is how it's written, that they, in order to get naloxone from the grant, they have to take a naloxone training that meets certain standards / the naloxone training developed by the grant. And so that's kind of what we've been going off of.
Yeah, I just wonder if we'd be able to add this in addition to that training. This one just seems so much more relevant to EMS providers, but I guess it is more about leave behind Narcan, but I don't know. I don't know. I would personally, as a medical director, find this way more useful to my agencies than the other training if I was going to do one. And this one does show you how to use naloxone. I guess there's less emphasis on recognition of overdose, but I don't know. I don't know. Maybe
This is Sandy. I did the training for my EMT that have STRs from Pinal County Sheriff's Office, and they didn't have to redo the training, and they got their naloxone from Rural Health.
Yeah, I'm not sure how they're checking that necessarily. So
AZ Post is the one that is really strict on.
Right.
But if they're EMTs, that might be easy. So if they're EMTs, then that's where they could get it from you, Sandy. Yeah. But if they're just law enforcement solely.
Right. And I had a PowerPoint, I had a test, I had, we had practical skills and the whole bit. So
yeah,
we met any requirement.
So I would say we just link it to, especially because by the time this gets to the committees and gets posted, it's going to be so close to the grant ending.
Yeah, I agree.
I say we just link to Office of Injury Prevention. But what do you guys think? Because my thought with this, when I first heard about this program, I'm like, what do you mean Narcan leave behind? I was thinking like you leave behind your leftovers. And that was funny because Josh Gaither thought the same thing. I remember like the journal club we were on. And then they're like, oh no, there's a standing order that your name's on. And so then I started doing research. And then when Melody actually implemented this, I think that's when it really has started to gain a little bit of traction. And so I would, I think trying to make this as easy as possible that any agency whose medical director is okay with this, they would have like minimal workload to do. So
yeah, totally. Yeah.
That is my thoughts, but well, I appreciate it. I think we are you guys comfortable? Shelley's going to do kind of the help with the administrative edits. I don't think we need to meet again for another work group unless you guys want before the actual education committee.
I don't think so.
Are you good with that, Sandy?
Oh, yes.
Okay.
I'm meeting today.
If we're all good, I think that we can say we all approve verbally the administrative changes. So
I think we're done.
all right, one and done. I like it.
Cool.
And ahead of time, too.
Yeah.
Pardon?
And ahead of time.
Yes. All right. Excellent. Well, thank you so much, guys. I appreciate it.
Yeah. Thanks a lot.
Yeah.
See everybody later.
All righty. Bye.
Bye. Thank you, Shelley.